presenting surgical site infection, going over a brief introduction followed by a review of guidelines and other recommendations based on evidence. So a survey that was done in low middle income countries done by WHO showed that the prevalence of hospital acquired infection is around 3 to 21%, and of those 5 to 34% were surgical site infections. In a study, so basically surgical site infection doesn't just cause morbidity, it also may lead to mortality, and in a study 77% of deaths of surgical patients were because of wound infections, and in another study the relative risk of death because of SSI was 2.2. So SSI also leads to increased hospital costs as well as increased cost of hospitalization. So definition of a surgical procedure, pretty basic, refers to an operation where at least one incision is made into the skin and mucosa, and surgical site infection is an infection that occurs after surgery in any part of the body where surgery took place. So there are three key factors which are playing in a role in the development of surgical site infection. One is the host himself or herself. The second is the bacteria or the microbiology, and the third are the surgical factors. This is a diagram which basically shows that there is a complex interaction of multiple factors that leads to a surgical site infection. So if there is increased, so there are three primary categories in which these are divided: the risk factors, surgical factors, anesthetic factors, and patient-related factors. Patient-related factors include diabetes, smoking, poor nutrition, alcoholism, and other factors that can lead to immunosuppression. Anesthetic factors include decreased tissue perfusion, decreased oxygenation intraoperatively, hypothermia during the case. Surgical factors include surgical classification of the wound, skin preparation, presence of suture or foreign body, suturing quality, hematoma, etc. So anything that the anesthetic factors and the patient-related factors could lead to decreased collagen synthesis, which eventually is a setup for decreased wound tensile strength, which may lead to wound breakdown and eventually poor wound healing. Vasoconstriction again leads to both decreased collagen deposition as well as decreased neutrophil activity, which again leads to the same course. Infection because of increased immunosuppression because of any of these three factors could result. So again pretty basic, there are four types of wounds: class 1 or clean and class 2 clean contaminated. These are the two categories that we usually include in surveillance of SSI. So in clean cases, respiratory, gastrointestinal, biliary and urinary tracts are not entered, and there is no acute inflammation. These are closed primarily. So for example, any lumps and bumps, breast surgeries, vascular surgeries, cardiothoracic surgeries. So clean contaminated cases include elective entry into these areas, that is respiratory, biliary, GI tract, urinary tracts with minimal spillage, for example appendectomy. So then these also determine the rate of infection. So for example, with clean surgery, even if you don't use antibiotic, the risk of infection is less than 2%, whereas in clean contaminated without antibiotics it's less than 10%. So in contaminated cases, that is there is presence of non-purulent infection or gross spillage from the GI tract, penetrating traumatic wounds less than 4 hours, and major break in aseptic technique. So around the risk of infection is around 20%. And in dirty infected wounds, that is class 4, there is pus, there is also preoperative perforation of viscous and penetrating trauma wounds. Infection risk is around 40%. However, so these do provide a rough risk assessment, but a better risk assessment is done when we consider three things. This is NNIS risk index, which is used by CDC in states, and this includes three factors. One is the physical condition of the patient, that is ASA classification, whether it's less than 3 or more than 3. The second is the class of the contamination of the wound, which is either class 1 and 2 or class 3 and 4. And the last one is the length of surgery, that the length of surgery is within the 75th percentile of the surgery duration, or it's more than that. So we attribute one score to each of these, and with that we have estimate of the predictive percentage of the SSI. So at risk 1, for example, the risk is around 2.9%, whereas at 3 it's 13%. So again a basic question, which is the sterile area of the gown? आपने surgical gown पहना होता है, उसका sterile area कौन सा होता है? Front का कौन सा part? Exactly. So basically the arms and up to the navel part is sterile. अब what does it translate into? जब gown हम लोग doff कर रहे होते हैं, so ensure कि you don't take your hand well away from the surgical field, ठीक है? Likewise, whenever somebody is passing an instrument, so just ensure that the instrument is not being passed from the back side of the person. So again, one more thing is that while you are trying to shift your positions, since the back is non-sterile, so ideally you should shift your position such that the back is against the back. So for example, अगर यहाँ पे एक person खड़ा है, so you should just turn around in order to shift the position. So I'll be going over these 4 guidelines. The NICE guidance is the recent one, but many of their indicators are from 2008 guidelines. Other than that, the most recent one is the 2009 Asia Pacific Society of Infection Control guideline. WHO guidelines were reported in 2018 and in 2017 by CDC. So shower and bowel prep. One, the recent guideline says that there should be a SSI monitoring program in the hospital. Other than that, with regards to shower, it is necessary for patients who undergo surgery to have at least one pre-op bath. The timing of the bath is not specified, but in most of the guidelines they say the night before the surgery or the morning of the surgery. There is no benefit of antimicrobial soap usage versus a regular soap usage. Other than that, for bowel preparation, specifically for colorectal surgeries, mechanical bowel prep alone is not recommended. Mechanical bowel prep should be combined with antibiotic prophylaxis as well, given orally as well as IV. So with regards to hair removal, as most people would know that hair removal should be done at the time of the surgery, either in the OR or in the pre-op bay, and it should be done via clipper. Patients should also be told that they should not remove the hair prior to coming in for the surgery, and in case they have to do it, it should be at least with a gap of 7 days. So with regards to MRSA decontamination, the recent guideline, the Asian Pacific guideline recommends that hospitals should evaluate the SSI rate, Staph aureus rate, MRSA rates, as well as mupirocin resistance rate, since we use this for decontamination of the nasal cavity. So in order to determine whether a surveillance program needs to be implemented or not. So patients undergoing cardiothoracic and orthopedic surgery, since they have a higher risk of having MRSA contamination during the surgery, so such cases have been recommended to undergo the nasal decontamination prior to surgery. So other than that, NICE recommends that nasal mupirocin in a combination with chlorhexidine body wash should be used in cases where Staph aureus is a likely cause of surgical site infection. So the other guideline just specified that it's cardiothoracic and orthopedic procedures. So with regards to hand decontamination, scrubbing can be done by using antiseptic soap as well as by using alcohol-based hand rub. However, for the first wash of the day, it's better to use a proper hand scrub, and then for subsequent procedures, only alcohol-based hand rub can be used. So where the water quality of water used is not assured, using of alcohol-based hand rub is recommended. If hands are grossly soiled between the cases, then it's preferable to use, then it's a must to use soap instead of alcohol based hand rub. Alcohol based hand rub does not remove the contaminants on the hand, it just removes the bacteria. So gross spillage agar hoti hai to you cannot use the alcohol based hand rub. So for antiseptic skin preparation now, so alcohol based, I'm really sorry, these are all guidelines, so these are pretty dry, but I'll see if I can add a couple of extra items. So alcohol based hand rub antiseptic preparations should be used unless contraindicated. So alcohol based solutions, especially those that contain chlorhexidine, are preferred for surgical wound preparation. However, in the absence of chlorhexidine, pyodine or povidone iodine can be used, but that too again would be preferred in case alcohol based, it's an alcohol based preparation. So the preparation should be done immediately before the surgery. There should be, there is a risk of developing chemical burns in babies in case chlorhexidine is used because of alcohol based, especially in preterm babies. And in case diathermy is being used, just ensure to dry off all the chlorhexidine and pyodine prior to using the diathermy, because it has been shown to be associated with a risk of burn. So in case, so these are the preferred solutions with decreasing priority. If you have alcohol based solution of chlorhexidine, that should be first priority for the antiseptic skin preparation. Second would be aqueous solution of chlorhexidine, then alcohol based solution of pyodine, and aqueous solution of pyodine. So now with regards to prophylactic antibiotics, CDC recommends that pre-op antibiotics should only be given if they are indicated. Indeed, every guideline recommends that. So NICE states those guidelines for us. So we should use antibiotic prophylaxis in clean surgeries involving placement of a prosthesis or an implant, clean contaminated surgery, and in contaminated surgery. Do not use antibiotic prophylaxis routinely for clean cases. The antibiotics should be given within the first, within 2 hours of skin incision. So whenever an antibiotic is administered, it should be ensured that by the time an incision is made, the concentration of the antibiotic in the body is enough. So maximum of 2 hours prior to the surgery, but minimum of 30 minutes prior to the surgery. It's preferred that antibiotic should be given prior to anesthesia induction. So redosing should be considered to maintain adequate tissue levels on the basis of agent's half-life. So this is a weak recommendation, but redosing is recommended only in Asia Pacific guideline. So with regards to, so I've already gone through these. So in case vancomycin powder is used in some of the cases for local application, that is not recommended. Likewise, Polyfex or any ointments or any preparations similar to these are not recommended for use in any kind of skin incisions. Only one indication, gentamicin collagen implants are recommended in cardiac surgery. So with regards to glycemic control, APSIC guideline recommends HbA1c levels of less than 8, and remaining guidelines recommend that the blood glucose target should be less than 200 milligram per deciliter in the perioperative time period. In case a person is not a known case of diabetes, he should not be started on insulin right away after a surgery, just so as to reduce the risk of surgical site infection. So with regards to hemodynamics, where the roles of the anesthesiologist comes in, so perioperative normothermia is emphasized in each and every guideline. So this is something that must be maintained. Other than that, hemodynamic goal directed therapy is recommended. WHO and NICE also recommend supplementing additional oxygen in patients who undergo major surgery during the surgery as well as in the first 2 to 6 hours after the surgery. WHO recommends FiO2 of 80%, whereas NICE recommends that saturation of oxygen of more than 95% should be maintained. So, just a question from surgical residents, surgical SMOs, मेरे colleagues से basically. So, जब आप skin prep करते हो with chlorhexidine or with pyodine, how much time should be given for it to be applied and then for it to be dried? हाँ, 2 minutes for drying time, लेकिन dry होने के बाद भी उसको थोड़ा सा time देना चाहिए. Dry होने के बाद भी मज़ीद 2 minutes के लिए wait करें. There was a randomized controlled trial on the adequate time of application of the chlorhexidine and pyodine as well as on its time for drying. The more time you give, the decreased are the surgical site infections. So, अब उसमें ये है कि application time 30 seconds to 2 minutes है, drying time around 2 minutes, but you can give 2 more minutes to pyodine even after it dries. So, platelet-rich plasma only for prevention of surgical site infection is not indicated, and transfusions should not be withheld with the mindset that they would lead to decreased surgical site infection. If transfusion is indicated, then please go ahead and give it. It has not been linked to increase in surgical site infection rates. So, with regards to intracavity irrigation for clean and clean contaminated surgery, there is insufficient evidence for recommendation of saline irrigation. However, CDC recommends intraoperative irrigation of deep or subcutaneous tissues with pyodine for prevention of SSI. Intraperitoneal lavage with aqueous iodophore is not necessary in contaminated and dirty surgery. So, only in clean and clean contaminated surgeries. Wound protectors should be carefully inspected prior to the start of the surgery to ensure that they are appropriate and there is no break in them. Laminar airflow is not required in new or renovated operating rooms to prevent surgical site infection as per APSIC guideline. So, with regards to antibiotic impregnated sutures, some of the guidelines NICE, CDC and APSIC recommend these, but there is recommendation in pediatric surgery by NICE, plus CDC recommends, no not CDC, sorry, APSIC recommends that in individual centers where the risk of SSI is higher, so those centers can consider antibiotic impregnated sutures. So, adhesive incised drapes overall are can be used, but only if they are iodophore impregnated drapes. So, these are cling films with adhesive part that attach to the skin of the patient, and they should only be used if iodine is present in them. So, other than that, with regards to dressings, simple dressings are fine. Vacuum dressing, negative pressure wound therapy and silver based dressings have mixed results. Aseptic non-touch technique for changing or removal of dressings should be used, and the wound dressing should be kept on for 48 hours. Patients can shower after 48 hours, and tap water should be used for cleansing the wound after 48 hours. So, a question, who is wearing the cap right? A, B or C? Dr. Ehtesham.
Why do you wear the cap?
Because it can increase the risk of surgical site infection actually in the OR. बाल साथ साथ गिर भी सकते हैं. So, it is recommended in guidelines that once the sterile equipments are exposed, the cap and mask should be in place. Basically, this is wrong because hair इसमें से बाहर निकल रहे हैं, they are sticking out. So, these two are fine because they are fully covered, there is no loose hair around it. So, that is how it should be done. So, a few other recommendations. So, ये pretty basic है. So, treat all infections prior to doing a clean surgery. otherwise delay operation. Patients should cease tobacco consumption. It's a strong recommendation. Optimize blood glucose level and avoid hyperglycemia. And so for the surgeons and the OT staff, keep fingernails short, do not wear artificial nails. With regards to nail polish application, there was mixed recommendation. So scrub hands and forearms as high as elbows for at least 2 to 5 minutes with appropriate antiseptic. After scrub, keep the hands up and elbows flexed. So what people do is after scrubbing and even during scrubbing, their hands are lower than their elbows, which is wrong because all the contaminated fluid goes towards the hands, which contaminates the hands, and basically the purpose of scrubbing up is lost. So masks should be worn in the OR if sterile equipments are exposed and throughout the surgical procedure, and should cover the mouth and nose. Hair on the head and face is to be covered up with a hood or cap. Liquid resistant sterile surgical gowns and sterile gloves are to be worn by scrubbed surgical teams. So they should be waterproof. Shoe covers are not necessary as per these guidelines. These are basically from randomized controlled meta-analysis and randomized controlled trials. So personnel with skin incisions that are draining should be excluded from the duty. So handle tissues gently with good hemostasis, minimize foreign bodies and minimize devitalized tissue and dead space. So बाकी mostly चीज़ें जो कि हमें पता हैं, take home messages कि multidisciplinary approach है. Everybody is involved in decreasing the risk of SSI, including the physicians, the anesthesiologists, the surgeons, as well as the nurses who are involved in the process. So we need to be vigilant, ensure sterile field is not breached. So let's say the instrument trolley, somebody touches in it, ठीक है? Then one of the persons, let's say the OT tech or one of the surgeons, just touches its side. So basically breach हो गया है आपकी sterile field में. Likewise, if the gown, if the surgical drapes are touching, let's say the diathermy pole, so that is again a breach in the sterile field. A person's arm, especially the front of the arm, touches somewhere, वो भी breach in sterile field है. And it's okay, it happens, but it's just that it needs to be addressed right then and there. If अगर मेरे गाउन कहीं पे टच हो जाए, I should change right away. Elective colorectal surgery, bowel prep with mechanical and oral antibiotic prophylaxis. This is something that is changed from the last NICE guidelines. Many people are still practicing mechanical bowel prep only. So we need to start giving oral antibiotics as well. Previously, oral antibiotics for bowel preparation was deemed unnecessary. However, a Cochrane review in 2014 again brought in the concept of using oral antibiotic prophylaxis for colorectal surgeries. So dressing should be kept on for 48 hours unless it is grossly soaked. So thank you so much. Questions? Yes, sir.